You're watching Coronavirus in Context. I'm Dr. John Whyte, Chief Medical Officer at WebMD. Have you been delaying going back to the doctor, maybe putting off that colonoscopy or mammogram? What's the consequences of that delay? To answer these questions in the field of cancer, I've asked Dr. John Deeken. He is the president of Inova Schar Cancer Institute. Dr. Deeken, thanks for joining me.
Thank you, John. Good to be here.
You know, for a long time, we were telling patients, don't come to the hospital. Now we're telling them, come back to the hospital. It's okay. It's safe. That can be confusing to patients. So what's the latest on the recommendations about how they decide whether or not to come back to the hospital or to the physician's office?
It's a great question because it's been a confusing and struggling time for all of us, for our families, for our neighbors, for ourselves, and for our patients. I think the good news is we've learned so much over the last 4 months about the virus, about protections that we need to impose, about effective screening, about the role of testing. So we've learned so much, I think, and every health system has struggled with this, but I think we've gotten to our new normal whereby we created a safe environment for patients to come to the emergency room or be in the hospital, for getting surgeries, and certainly for getting cancer treatments and also screenings now in a safe and effective way. So I think we've provided those environments and those precautions to make it safe for people to return for those aspects of care they should not postpone. And certainly cancer treatment, cancer screening are areas that we should not postpone.
You know, we've been talking on the show that, in many ways, a hospital or a cancer center right now is safer than a grocery store or safer than a lot of other places. And we're saying the reason why that is everyone's getting temperature checked. There's good infection control, trying to control physical distancing and not having people typically in the waiting room as usually would occur pre-COVID. Help us understand, how do we convince patients that it is safe to come back? We can say it is, but how do we help them recognize that?
You bet. I mean, I think a good thing that a patient should do before they go in is ask the questions to the clinic staff when you're making your appointment. What are they doing for the precautions? Are they doing temperature checks? Is everyone wearing a mask? Are they having people sit in the waiting room for a prolonged period of time, or are they rapidly getting people from their car to the exam room so that there isn't that waiting in that larger area? I think those, like any good consumer, you can ask those tough questions, and if you don't get good answers, then think about whether you should go in or change the place of care. Most places, we've learned so much that most places have put in place very effective, those screening technologies, those pathways, and those mechanics of allowing patients to be, to not have to wait, in public areas with a lot of other patients in waiting rooms, that sort of thing. So
that's a good thing, because we were used to waiting a long time. And cancer centers such as yours typically have separate entrances than someone who would go in with symptoms of COVID. Dr. Deeken, I want to get to this issue of screening for those patients who don't know whether or not they have cancer, don't have signs and symptoms of cancer. So we're talking about screening. And we've interviewed people early on in March, and they would say, you know what, it's okay to wait a month or two for your mammogram. But now we're approaching 3-4 months. What happens is people don't come back at all this year. They may lose their insurance. In some areas, mammograms are down, correct? 75, 80, 90%, even colonoscopies. Help our listeners understand, what are the consequences?
The huge advance in cancer care over the last 30 years has been early detection and by screening. And we talk about screening, we're looking for early stage tumors or pre-cancer lesions that might turn into cancer. And we know that our whole cancer staging system is set up to better understand cure rates and treatment modalities. So if you have a stage 1 early cancer, high cure rate, easily treated, probably only needing one modality of treatment, just surgery or just radiation. Where if it's higher stage, the prognosis is worse, and that's a time issue. That's the longer a tumor has to grow, the bigger it can get, the more readily it can spread. So that's why screening and early detection have made our cure rates in the U.S. so dramatically improved over the last 30 years, is by those initiatives. And for some cancers, every month matters. We're starting to see in for example, our melanoma skin cancer clinic, patients coming in with more advanced tumors. They're deeper in the skin. They've already spread to lymph nodes. And that's probably because they weren't getting those screenings for those months. And that's a disease where months matter. So we don't want to put off those kind of screenings now that we've learned to create the safe environment for patients to come in. Back in March, it was a different thing. But now we've had these safety precautions. You don't want to put off those screenings that we know save lives. Across our society and individual patients, it saves lives. So we shouldn't be putting those off if it's safe where you are.
National Cancer Institute estimates in excess of 10,000 cancer deaths due to delayed screening. Other organizations have put it at even higher, 50,000, 60,000, excess cancer deaths. Patients are trying to evaluate risk. Let's be honest. They're saying, I don't want to go in to a center or an office or a hospital because I'm scared of getting COVID, right? Versus, I need to get my colonoscopy, which you and I know, people, I still see patients, that's something they're always canceling. They forgot the date, they didn't have a driver to take them.
Right.
They don't like the prep.
Right.
So really to reinforce when you're weighing risk, and correct me if I'm wrong, everyone's a little different. You have to, estimate the risk, with their physician, but the risk of catching COVID, for screening is in a cancer screening is much less than perhaps missing an early stage cancer that could be receptive to early and aggressive treatment.
By all means. And much of what we can do for screening is a combination of in-person and virtual. A lot of times that discussion you can have with your primary care physician about what screening is appropriate and the timing of that can be done via, virtual telemedicine visit. Obviously, the colonoscopies, the mammography, the breast exam, the prostate exam, all that needs to be done in person. Lung cancer screening in person with CT scans. But again, most places have set up so by, that one-stop quick shop for things like a CT scan, a mammography, or a colonoscopy is done rapidly. And oftentimes, especially for procedures, patients are being tested prior to those procedures for COVID, and obviously all the staff are protected and wearing high degrees of personal protective equipment to keep the patients from being exposed. So those are being streamlined at most centers so that again the risk is minimized as much as possible. And certainly the need to catch early lesions far outweigh those risks at most centers now in our country. COVID infection, as we've learned, is high risk, and for certainly older patients, higher risk in terms of outcomes. But cancer left to its own devices can be a death sentence. So we don't want to put off those colonoscopies, those mammographies. And again, the timelines for those are no less than every 10 years for a colonoscopy, no less than 1 to 3 years, depending on your age, for a mammogram. We don't want to push that much more than that because, again, tumors left to grow will be higher stage and have a lower chance of cure.
What about some of these apps for skin lesions? Are those adequate in terms of getting checked out for potentially melanoma or others, or are they leaving some things behind?
Well, that's a great question, because our dermatology team here, for example, is one of the teams that really couldn't make the jump to a high degree of virtual telemedicine visits. They need to see the lesions under the microscopes they use in the clinic. So our clinic in melanoma skin cancer and screening is more than 90% in person, and again, set up to be very safe for those patients that come in and come out. It's really hard to see the nuances of what could be a benign lesion versus an early cancerous lesion versus a full-blown squamous cell, basal cell, or melanoma cancer lesion. And I would not, we're not there yet with any sort of virtual evaluation of those. But now that those clinics have opened back open, that oftentimes needs to be in person, again, done in a safe way. But we want to catch those abnormal lesions early and treat them at the early stage.
And those apps serve a different role, and certainly in discussion with their physicians. I talked to a physician a couple of weeks ago, and you've been an oncologist for many years. He's actually head and neck surgery, and he would talk about almost once a week for the last 15 years. he would see a patient who presents with previously undiagnosed, cancer lesion. And for the last 4 months, he hasn't seen anyone that's presented that way. So where are those patients going? It's not all of a sudden, we're having a decreased incidence of cancer. I think that's the concern that many clinicians have, that delayed care then becomes, they don't come back year, 2 years, maybe not till it's at a much later stage. Have you had that experience over your career in terms of,
I focus on head and neck cancer, as you mentioned, and the average time from when a patient, and they're mainly males, most patients who have cancer are males, and we're probably not the most aggressive in terms of seeking primary care or screening care as a gender, but the average time between a patient noticing something, a lump in their neck, a soreness in their throat, is 9 months between that symptom onset and being diagnosed with cancer in the US, 9 months. And that time doesn't help. It's probably been brewing for years before then, but by the time it got big enough and billions of cancer cells enough to be symptomatic, that's when exponential growth of that tumor is going to increase the risk for it spreading locally and then distantly. And as soon as it spreads elsewhere, we can no longer cure it. So if you add to that 9-month average delay, 4, 6 more months because patients don't want to come in because of COVID, then again, the risk of that is increased. I think there's certainly many patients, and we're certainly seeing it in some of our disease areas, where that nagging problem or that delayed screen is still being put off. And we'll see over time how much that increases the higher stage presentation of cancer patients and therefore the decreased cure rate. But unfortunately, that's going to be in the rearview mirror when those patients have already suffered worse outcomes. And that's why it's our job as physicians, and I thank you for this sort of discussion, to highlight this for patients. It should be safe now. Check it, make sure you're comfortable with the safety, but don't put it off. So we often see that across the board, and I do think we're seeing it now, unfortunately, even more.
Let's talk about, for a minute or two, those patients that already have cancer, that perhaps their treatment regimen has been interrupted or changed by the COVID pandemic. Perhaps they were changed from an IV to an oral medicine, and they have some anxiety about that, or an elective surgery in terms of an aspect of their cancer treatment has been delayed. And in some areas, we're seeing cancellation of surgeries again. How do they deal with these changes? And what do you expect, in the next month or so in terms of a greater resolution to kind of pre-COVID treatment of cancer?
Great question. And I think, as we're seeing this evolve and becoming a bigger issue in parts of our country, in the South and the West, there are a lot of lessons we learned early on in March, April, May from the Northeast and the Northwest. And all of our cancer societies have put out recommendations about how to handle a newly diagnosed cancer patient in this era. And we've pivoted pretty well, I would say, as a community, to things like, if you can't do surgery right now because the hospitals are overwhelmed, do the chemotherapy first, because a lot of our cancers, you can do chemo first, then surgery, or surgery, then chemotherapy. And if they're equally curative, then you can alternate delivery of care and keep out of the hospital if your hospital is that overwhelmed right now. So we've learned a lot, and a lot of the societies have given us guidance based on the data we have to say what is safe and how we can alternate that therapy to make sure we don't delay, but we maybe stagger what is done first versus second versus third. And again, we've learned a lot, and that we can deploy, I think, at this time, because again, as you say, a lot of hospitals, a lot of health systems might not be able to do that surgery that is a suspected cancer surgery, but if we have a diagnosis, a biopsy, then we can move forward with treatment, radiation, chemotherapy first, and then that surgery gets kicked down the road a few months, and then hopefully things are better by that time if your area is a current hotspot.
Are we going to see more cancer care delivered in the home?
That's a great question. I think there's a lot of people looking at that. For chemotherapy, it's an interesting area right now where certainly we're having more and more.
They couldn't have it at home, and now.
Right. So I think there's a lot of interest in certainly oral chemotherapies and how we monitor those and can use those from home. Most of our chemotherapy drugs, even newer immunotherapy drugs that are much safer, that have fewer side effects, They still have some risks in terms of acute events during infusion. There's a rare patient who has an allergic reaction that we need to be there if that happens. So I'm worried there might be pushes from either payers or from patients who want to get that care at home or not in a setting that can provide that urgent delivery of resuscitation if they have a bad reaction to a medication. So I think there's a lot of attempt at looking for that. I hope we don't use COVID as an excuse to provide lower cost care that might not be as safe or as good. And it's our job as the physicians to, call balls and strikes about what's safe and what might not be, if we're getting pushed to do that from insurance companies. And it's our job to convince patients of what's necessary to keep them safe when they come in, but still have them come in for some of that acute care. Now, we've seen at our cancer center, we took obviously a pivot quickly to telemedicine early on, but our active treatment, chemotherapy, radiation, sort of stayed fully active because all those patients that needed care didn't change at the end of March when all this started. So that's we've learned a lot, and I think are providing that care, and we can reassure patients that it is safe to come in for that, and they definitely, if they have cancer, should not delay treatment in any stretch.
Well, Dr. Deeken, thank you for taking the time to reassure patients about the importance of those screenings, about the importance, as you've talked about, dialogue with your physicians. Hospitals and physicians' offices and cancer centers are, by and large, safe to go back to. You want to look at the individual one and talk to clinicians. Any other tips for our listeners?
No, I think just stay safe and be assured that we're learning a great deal along the way. This is a difficult journey for all of us, for our country, for our families, but we've learned a lot, and we're doing, and it's up to the physicians, I think, to reassure patients and put those safety precautions in place. But cancer didn't stop for COVID, so all of us oncologists haven't either. Know that it's safe, and cancer screening, cancer care is as important as it ever was. So talk to your physician, get your screenings done, and if unfortunately you have cancer, be assured that we can do that in a safe way despite COVID for as long as we have to deal with this.
Dr. Deeken, president of the Inova Schar Cancer Institute, thanks for joining me today.
Thank you. Thank you, John.